Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity entitled A Clinical Wake-Up Call, Diagnostic Strategies and Novel Therapies in Idiopathic Hypersomnia. Today's program is supported by an educational grant from Jazz Pharmaceuticals. This activity is brought to you by CME Outfitters, an award-winning joint accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We'll be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we're using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and the platform as well. Again, my name is Dr. Michael Thorpe, and I'm Professor of Neurology at the Albert Einstein College of Medicine, as well as Director of the Sleep-Wake Disorder Center, Department of Neurology at Montefiore Medical Center in the Bronx, New York. Now, let me introduce you to our faculty. Joining me today is Dr. Yves Dauvier, Professor of Neurology and Physiology at the University of Montpellier, Director of the Sleep-Wake Disorder Center, Department of Neurology at the Guy de Chalac Hospital in Montpellier, France. Welcome, Yves.
Hi, Michael. Thanks for the invitation.
And we have Dr. Nancy Folvery-Schaefer from the Cleveland Clinic Neurological Institute. She is Professor of Neurology at the Cleveland Clinic Lerner College of Medicine, Director of the Sleep-Wake Disorder Center, and on the staff of the Epilepsy Center in Cleveland, Ohio. Thank you for joining us, Nancy.
Thanks, it's great to be here.
To frame our discussion today, let me begin with our first learning objective, which is to recognize the quality of life, functional and clinical impact of idiopathic hypersomnia so that we can strengthen our interaction and discussion with patients. First of all, we want to hear from the patients as to what your perspectives are on idiopathic hypersomnia and the impact of this disorder on the patients. So we have a question for you to answer. When evaluating a patient with idiopathic hypersomnia, how important is it to assess the quality of life and functional impact of IH? So A, not important at all. B, somewhat important. C, important. D, extremely important. Please vote now. We're going to discuss the results later, so we won't be showing the results immediately, but we will discuss them. Okay. Idiopathic hypersomnia is a rare chronic debilitating disorder, and therefore listening and hearing from the patient is really essential. So let's listen as Addison, who's a young woman living with idiopathic hypersomnia, shares how it has impacted her life as well as her self-perception.
I always was considered kind of lazy. I remember being in 7th grade Spanish class and learning like adjectives that describe people and saying, oh yeah, perezosa, that's me, I'm lazy. Because I would just sleep all the time. Like it wasn't even something that other people were saying about me. It was something that I had internalized as well. It made sense to me. I slept all the time. I was exhausted all the time. So I couldn't do as much as I wanted to, so I must be lazy.
So, Yves, it is clear that idiopathic hypersomnia can have a devastating impact on the patient, their families, and society as a whole. And these patients present with tiredness and fatigue and excessive sleepiness, but idiopathic hypersomnia really differs from other disorders that have excessive daytime sleepiness. Can you discuss the differences between excessive daytime sleepiness due to other disorders and the hypersomnia that we see in idiopathic hypersomnia?
Yes, for sure. Thanks. We need really to differentiate these symptoms, excessive daytime sleepiness and hypersomnia. For sure, these two symptoms exist in IH, but that may exist in other conditions. Excessive daytime sleepiness is an ability to stay awake during the day and with different phenotype, feeling of daytime sleepiness, with sleep attacks, with naps, planned naps, unwanted naps, and automatic behavior. And that exists in many different conditions, IH, as we will discuss today, but also narcolepsy, OSA, sleep deprived. In contrast to EDS, we do see patients with a long sleep at night. They have excessive quantity of sleep or increasing need for sleep. And that could be during the night, during the day, or both during day and night. And patient may sleep more than 12, even 14 hours a day. And often they complain about sleep inertia in the morning. And we do see that in IH, but also in long sleeper and sometimes depression. So yes, we need to differentiate these two major symptoms.
Good, thank you. Nancy, idiopathic hypersomnia is a heterogeneous disorder. It's really composed of two different sort of subtypes. One, there are patients who sleep relatively normally during the night and yet are sleepy during the daytime. And then there's another group that tend to have a long sleep episode at night and are sleepy during the day and have, an excessive amount of sleep during the 24-hour period. The symptoms sort of vary between these two types. I wonder if you could just discuss with us some of the differences between the symptoms in each of these two types.
Yes, the symptoms of idiopathic hypersomnia, both long sleep and without long sleep, were really nicely displayed in this study that was the Hypersomnia Foundation web survey that was completed by 468 patients with IH in 2016. And so what we clearly see is that almost all patients report excessive daytime sleepiness on this survey, but also high prevalence of having trouble waking up in the morning and functioning early in the morning. This is sleep inertia, brain fog, difficulty remembering things, and requiring repeated alarms to wake up in the morning. This is also part of the sleep inertia symptom, are reported by both groups. But there are some differences. Patients with long sleep time tend to have more pronounced difficulty waking up in the morning. They also tend to require more alarms or more other strategies to wake up in the morning. And they also report more brain fog and intentional napping. So there are some differences between them, with long sleepers having more symptoms.
Very good. Now, Addison gave us a great description of how her sleepiness and hypersomnia is affecting her. But there are other things that can impact the individual as well. Would you like to discuss a little bit more about those features?
Sure. Idiopathic hypersomnia affects virtually all domains of quality of life. Many patients will say that they don't feel supported by their family and friends, even their employers. This is often because their family, friends, and even employers don't understand the condition and or consider them lazy. Patients will have difficulty with interpersonal relationships. We see here 13% reported divorce or having a relationship breakup because of their symptoms. And also patients will have a lot of difficulty on the job. 26% have reported being dismissed from their job. Some have to relocate or move closer to their job so that they can get to work on time. And many don't have flexibility in their work. And this is certainly a condition where flexibility helps quality of life. I think all of these things lead to patients feeling isolated and lonely, and these things can also impact mood.
Very good. symptoms affect the patient, but it's not just the patient that's involved with idiopathic hypersomnia, is it? I mean, it does have an effect on the family as well. And so why don't we hear from Addison's mother as to what impact she has felt from Addison's excessive sleepiness.
It's been really tough for everybody to watch what's going on. As I said, from a young age, we knew how gifted Addison was. And then to watch her issues with the IH, even before we knew what it was, hold her back. And then the worry starts to come in, and just concerns like, okay, I would have families say to me, all right, Michelle, you're getting Addison up. She's getting to school. She's functioning because of you. What happens when she goes off to college? What happens when she gets a job and she moves out? Is that something that she's ever going to be able to do? People have, made some comments about that. How do you kind of separate at all? How is that going to work? What does it look like, with Addison moving into adulthood? It sounds like she's always going to need you. She's always going to need you to be there. Her sleep issues, is she ever going to be able to work a full-time job? What happens if she has to be in early for a project? What if she has to stay late, to do something? So there's been a lot of concerns. There's been a lot of worry. It's always been a worry. And there've been things where we plan stuff around Addison's schedule, her sleep schedule, her things, maybe a family function or an outing or whatever. I'll meet you guys there at 1 o'clock instead of 12 o'clock because I've got to give her time to sleep, to wake up. Otherwise, she's not functioning all day. And then it's just the whole overall, like, she is bright, she is gifted, she is well-spoken. There's nothing that has come at her that she hasn't been able to handle or to do or to achieve. And the biggest thing holding her back right now is the sleep issue, and I should say more so prior to her getting treatment. That seemed to just interfere and set that off. So that's always been my worry, the family's worry. I know that she's capable of great things, but if she can't get up and get there to do them, what happens then?
Well, Addison's mother really gave us a good idea about how Addison's problem is a concern, a great concern for the family. But there are a number of other areas too on how the impact can occur on patients' families and on society as well. So Nancy, can you discuss a little bit more about how this disorder impacts the family and society?
Yes, Michelle's perspective is identical to the perspective of so many parents and spouses and other family members and friends of my patients. The symptoms of idiopathic hypersomnia can be as distressing to loved ones as they are to the patient. And they affect the whole family, and they affect the work environment and the broader, society. The inability to wake up and maintain, and the need to kind of conserve energy to be able to do chores and responsibilities really leads to people needing help in many domains of daytime functioning. And this often relies on family members to help them, even with simple tasks that most adults and teenagers would be able to do on their own. I think it's particularly difficult for people to attend to tasks when they've had to wake up in an unplanned way, like in the middle of the night caring for infants and children. This often requires support. It's also difficult for people to get going in the morning. Again, this is the sleep inertia that's a core feature of idiopathic hypersomnia. And so mothers, for example, who have to wake up and get their children off to the school bus, this is very difficult and can really affect the dynamics in the household. And finally, there's a risk of falling asleep behind the wheel, and there's an increased risk of accidents in these patients. So Michelle mentioned that as well, the concerns about safety, the concerns about whether Addison will ever be able to really work a full-time job or work at all because of all of the symptoms that affect daytime functioning safely in people with idiopathic hypersomnia.
Very good, thank you. Eve, I know you've had a lot of experience with patients with idiopathic hypersomnia. What aspects have really impacted you about the symptoms in patients or the families of idiopathic hypersomnia? What really stands out for you as being a major source of concern for these patients and families?
Yes, I agree with Nancy as well. That is really burdensome, and there is a lot of consequences on daily life about driving, about working, about taking care of about kids, about the family. So it's not just the symptoms driven by sleep inertia, by hypersomnia, and by daytime sleepiness. There is a huge consequences on daily life and on many different aspects, and we covered that, and especially Michelle, about work, about social, about families. So yes, we need to recognize this disorder as we did in the past with narcolepsy, but is less known for IH. So hopefully today we will convince everybody that this disorder need to be take care into account to improve the quality of life at the end.
Yes, in a way, it's a little disappointing that this disorder has this name, idiopathic, because I think when people hear idiopathic, they tend to lessen the severity of the condition. But as we've heard from both of you, from Michelle and from Addison herself, this is really a disorder that has very disabling symptoms, and it's a major concern to both the patient and the family. So it's a disorder that really needs to be taken very seriously. Okay, so why don't we move on now to our second learning objective. And what we want to do here is to try to find out how we accurately diagnose idiopathic hypersomnia. But again, before we go on to that, what I'd like to do is to ask the audience another question. So if the audience can come in and answer the question, how confident are you in accurately diagnosing idiopathic hypersomnia? A, not confident at all. B, somewhat confident. C, confident. D, extremely confident. Or E, you don't know. So please vote now. And again, we'll be discussing the results later in the program. Okay, so thank you for answering that question. You know, it's when a patient's presenting with symptoms that seem sort of, in a way, quite common, like excessive sleepiness, because everybody suffers from excessive sleepiness, it's a challenge to be able to find out what the actual diagnosis is. And we certainly all feel very rewarded when we can come to an accurate diagnosis. But unfortunately, it often takes too long to get to that diagnosis, and finding an accurate diagnosis for symptoms of hypersomnia and excessive sleepiness can be very challenging. So let's go back to Addison and hear what Addison has to say about getting a diagnosis.
I feel that clinicians need to detect idiopathic hypersomnia earlier because anyone can be the person who says, you seem like you're sleeping a lot, or does sleeping that much ever affect you, your social life, your school life, your work life? Anyone can be that person and say, maybe you should be referred to a sleep specialist, or maybe I'll refer you to a sleep specialist. I just think that I mean, even just hearing my mom talk about the worries that she and my family has, like I have them too, but just hearing it come from someone else, it's hard to hear, you know, that there's this constant worry that there could be things that I want to do that I can do, but that I'm not awake to do. So then I'm not able to do them. I think anyone I saw had the ability to say, you need a sleep specialist, someone who had the knowledge to help from a clinical standpoint.
So, Eve, we've heard from Addison about her concerns about getting a diagnosis, but there are a lot of challenges in making an accurate diagnosis. Can you talk to some of those things that prevent us from getting a diagnosis quickly with this disorder?
Yes, Addison comments are clear. There is a long delay to be diagnosed. And again, a lot of patients with IH are not yet diagnosed in US and in Europe. So because there are frequent complaints, as we discussed already, about excessive daytime sleepiness, hypersomnia, and sleep inertia. And this symptom may exist in many different conditions and not only in IH. So we really need to be sure about the diagnosis of IH. So first, we need to exclude other sleep disorder, namely narcolepsy type 2, and we will discuss that a bit later on, but also circadian rhythm with delay of sleep-wake cycle, OSAS, and long sleeper. This is for primary sleep disorder, but mood disorder, so psychiatric disorder, may also mimic symptoms sometime on hypersomnia and excessive daytime sleepiness. And patient would take drugs because CNS drugs, sedative medication, or they stop medication that may alert you at maximum, like amphetamine, that may drive you to be drowsy as well. And also, sometimes a patient have past medical history of TBI, chronic fatigue syndrome, and it's not easy to be sure that patients are affected with IH, I for idiopathic, or if there is a comorbid condition that may explain better the complaint of sleepiness or hypersomnia.
Good, thank you. I mean, as you have mentioned, there are a lot of different disorders that can mimic the symptoms of idiopathic hypersomnia, and we really need to try to sort these out. But one that you mentioned that's really important is narcolepsy, because there's a lot of overlap, isn't there, between some of the symptoms of idiopathic hypersomnia and narcolepsy. You know, we know that there are two different types of narcolepsy. There's a type 1 with cataplexy and the type 2, which doesn't have cataplexy, but they overlap a lot. Can you discuss that a little bit?
Yes, thanks, Mike, to take that into account, because it's very key, because these three disorders, IH, NT1, and NT2, are certainly the more severe hypersomnolence disorder in humans. So when patient is very sleepy, you need to think about this disorder. So NT1 is very known because of the pathophysiology. It's clear with orexin deficiency, with cataplexy, that is pathognomonic, is a loss of muscle tone triggered by strong emotion. And we do see MSLT below 8 minutes and at least 2 SRM on the MSLT or during the PHG at night. And we do see also other other symptoms, sleep paralysis, hallucination, and disturbed nighttime sleep. So this is really typical for narcolepsy type 1. And narcolepsy type 2 is really complex as well to be diagnosed, because they share with NT1, MSLT below 8 minutes and 2 SRM, but there is no cataplexy. The CSF for orexin measurement is normal. We do not know clearly about disturbed nighttime sleep, sleep paralysis, hallucination. So it's not very easy to diagnose this condition. And on the right part of the figure, as you can see, is IH. And IH is also very heterogeneous, because sometimes it's overlap with NT2 because of severe sleepiness during the day and less SRM, less hallucination, less sleep paralysis, sleep inertia. But On the other way around, the form with sleep, long sleep time with sleep inertia is probably a little bit different than IH with very sleepy during the day. So there is overlap, you know, with common symptoms and especially excessive daytime sleepiness shared by the three condition. But on the extreme, there is cataplexy for NT1 and long sleep at night, and especially sleep inertia as well for IH. So it's not easy all the time to be sure that one patient is affected by NT1 or NT2 or IH, depending on the comorbidities, symptoms, and characteristics on PSG and MSLT.
Okay, so as you say, it can be quite difficult sometimes to distinguish between these different disorders, but you have developed an algorithm to help clinicians be able to sort these disorders out. Can you discuss that algorithm with us?
Yes, thanks, Michael. We started here with the definition of NT1, NT2, and IH on ICSD 3 criteria, with EDS in all the conditions. But EDS means nothing because the phenotype is different between NT1 and IH. As an example, with short naps versus long naps, refreshing versus non-refreshing naps, dream content, sleep attacks. So it's very different. They are sleepy, okay, but it's not the same sleepiness phenotype. We discussed already about cataplexy, hallucination, obesity, precocious puberty, and disturbed nighttime sleep in NT1. And in IH is mostly hypersomnia and sleep inertia, but this is not in ICSD's 3 criteria, unfortunately. The MSLT is very typical for NT1, as I already discussed, below 8 minutes for the latency and at least 2 SORM. But for IH, it's non-typical at all because you can have abnormal MSLT below 8 minutes, but sometimes in half of cases, it's normal MSLT. And so you need to record sleep during the night and during the day, so a long-term recording, at least 24 hours to record objectively long sleep at night, above 11 and sometimes even more across the 24 hours. And you need also to measure sleep inertia. And this is not really validated in ICSD-3. And if we want to go to ICSD-4 or ICSD-5, I don't know, we need probably to change a little bit the criteria. Because, you know, NT2, mostly in clinical lab, there is no CSF or measurement of hypocretin because you need to do LP, it's costly. And most of patients worldwide with narcolepsy do not have this orexin measurement. So it's just based on cataplexy, yes versus not. But when you do that, like in my lab in routine CSF orexin measurement, you can see that patients with narcolepsy without cataplexy, in 20% of them have low orexin level. So for that, there is an overlap between NT1 and NT2, because if there is no orexin, they should be labeled at NT1. Again, for IH, if it's IH with long sleep time, with very prolonged sleep, with high sleep inertia, it's very different phenotype, like IH with very high sleepiness during the day, with 1 or 2 SORM, but with normal sleep duration. And this IH with normal sleep time is probably closer to NT2, because it's just 1 SORM that may differentiate narcolepsy type 2 and IH with normal sleep duration. But you know, when you do and redo MSLT in the same subject after 2 years, 3 years, 4 years apart, this has been done in my lab, in Atlanta, and in Stanford, and there is variability in the sleep latency and number of SORM. So it's not very stable. So we cannot trust only the 0 SORM, 1 SORM, or 2 SORM. So again, we wanted to propose a perspective in the classification with narcolepsy spectrum and IH as a continuum with different phenotype. And to end this slide is of interest because, unfortunately, we call that idiopathic, as Michael already reported, because we do know nothing about the etiology, the neurobiology. And if we are able to phenotype at best this patient with more different category. Hopefully soon we can recognize some neurobiological defect.
Very good. Thank you, Eve. You mentioned the ICSD-3, and I think a lot of our audience may not actually be familiar with that acronym. It stands for the International Classification of Sleep Disorders. And this is the main classification system that's used by sleep clinicians worldwide to try to understand the differences between different sleep disorders. So Nancy, perhaps maybe you could tell us, what does the ICSD-3 tell us about idiopathic hypersomnia?
Sure. I love the previous slide, Yves, and because it really illustrates how simplified the ICSD-3 criteria are, which can lead to confusion and probably misdiagnoses. The ICSD-3 criteria does not differentiate from long sleep or short sleep duration as the ICSD-2 had. In terms of clinical criteria, one must have daily episodes of an irrepressible need to sleep or lapses into sleep lasting for at least 3 months. We'll see this is the same clinical criteria in terms of EDS as it is for narcolepsy. Fewer than 2 SORMs on MSLT, or fewer than 1 on MSLT if there's a nocturnal SORM on the PSG. One must not have cataplexy, and one must have at least one of the following. First is a mean sleep latency of 8 minutes or less, and second is a total 24-hour sleep time of at least 660 minutes on a 24-hour PSG or wrist actigraph that's averaged over 7 days. It's really important to rule out insufficient sleep syndrome. And so the actigraphy in advance of the PSG would help to do that. And of course, other sleep disorders and other medical, psychiatric disorders, and even medications should be excluded for a diagnosis of IH to be made.
Very good. Thank you. Well, both you and Eve have talked about the difficulties in making this diagnosis of idiopathic hypersomnia. And our diagnosis really rests on the polysomnographic studies, the nighttime sleep study, the MSLT. And so I wonder, Nancy, can you discuss with us what are the difficulties with that MSLT and being able to make a diagnosis? And then after that, we'll have Eve talk a bit about the nighttime sleep studies and how they might be improved, actually, to give us a better diagnosis. But first of all, what about the MSLT, Nancy? What do you see as the difficulties there?
Sure. Well, the MSLT assesses daytime sleep propensity, ability to sleep in a controlled laboratory environment, does not assess other symptoms of idiopathic hypersomnia. And the standard MSLT protocol was designed many years ago for narcolepsy. And so the established cutoffs are based on narcolepsy patients. Findings on the MSLT in narcolepsy tend to be stable and very abnormal. One of the challenges with the MSLT in patients with idiopathic hypersomnia is that, as Yves mentioned, a significant number of IH patients do not have a short mean sleep latency. They have mean sleep latencies over 8 minutes. This has been found in a number of studies, and including a very eloquent study that Yves' group published that illustrated the variability of mean sleep latencies over time in IH patients and the variability of SORMs. In fact, in his study of only 25% of patients with IH who met criteria in their first PSG MSLT evaluation continued to meet criteria for IH at a later point in time when retested. The others reverting to normal on the MSLT or to narcolepsy. And others have also found that patients with IH and narcolepsy type 2 may have findings that shift back and forth over time. So this is very problematic because I think most patients and most clinicians would expect to do this test one time and to get a result that's valid. But in fact, this assessment, as we do it, at least currently in the United States, probably requires repeat assessments, at least in a subset of IH patients.
Very good. Eve, can you tell us a little bit about the polysomnogram and what the difficulties are there in making this diagnosis?
Yes, everybody agree when you see patient with IH that they are not always very sleepy. So you cannot exclude the diagnosis of IH if your MSLT is normal because of the complaint of the patient. So you need to do more. And so what we propose in my lab is to do the PhD MSLT, and if it's not very confirmatory to the diagnosis and that exclude narcolepsy as well, you ask the patient to come back after a few months interval. We redo the PhD MSLT. We modify slightly the MSLT to awake the patient after 1 minute of sleep to prevent him to sleep too much during the day for sleep homeostasis. And after we put the patient in a bed for 1 night, 1 day, 1 night, so 32 hours. And this is of interest because in most of cases, this because several other centers, especially in Europe, did so for 24 hours. But we were interested to assess the second night to exclude long sleeper, because when you are young and IH subjects start the disease very young, about adolescent and young adults, and at 20 years old, you can wake up at 12 years old and you can have a nap in the lab when you have nothing to do. So if there's just long sleeper, you will have bad sleep the second night. If it's IH, you will have normal sleep the second night. So this is an example of a control. You wake up spontaneously, so there is no light, no TV, no watches, no computer. So it's in free running, and he's in a bed, and he will ask for a meal. So it's a little bit complex, but the patient wants to sleep because it's the complaint. So for the control, it's complex because he is in a bed for nothing. So he will wake up, as you can see here, around 7 and 8, have one nap because nothing to do in the lab. And after he will have a second night, a little bit shorter than expected because he already have too much sleep, especially with these long naps. For IH subject, as you can see here, he will wake up very, very late. Look at the 10th cycle. And after 2 hours awake, he go back to sleep with 2 cycle. And after, again, as you can see here at 8 p.m., he will have another nap. And he will continue to sleep the second night. And for this subject, you cannot, it's IH, typical IH, and is this guy, as an example, have normal MSLT. So based on that, we recorded more than 200 subjects in my lab, and we published that in Annals of Neurology to validate this protocol, and we defined some cutoff. And the cutoff was 19 hours for the 32 hours, or if you want to go just for the 24 hours, is 12 hours for the significant cutoff to differentiate patient and control. So in my hands, I think that to be sure of a diagnosis that will need to be medicated, you need to be sure of the diagnosis. And I think is the only way to go perfectly, I may say, even if it's costly probably in US, as we can discuss at the end.
Right. Well, I think your 32-hour assessment very clearly shows us the difference between a control patient and a patient who has idiopathic hypersomnia. So it really does make a big difference in being able to get the information we need to understand if somebody has idiopathic hypersomnia. But as you say, there are some difficulties with the testing, particularly here in the United States, where it's not an accepted test and therefore not reimbursed by insurance carriers. So we have some difficulties in the USA versus Europe in being able to do this. But I think it's pretty clear from what you've shown us that it is a test that can really make a difference in understanding the patient's symptoms. Now, in addition, you've also developed a measure of severity for patients with idiopathic hypersomnia called the Idiopathic Hypersomnia Severity Scale. Can you tell us a little bit about that scale and how it's scored?
Yes, thanks, Michael. So we developed a few years ago a scale to quantify symptoms of IH, as we did in the past for narcolepsy, because we wanted to, with the patient and patient association in France, to really detail all the symptoms that may be problematic for the patient. So we focus mostly on long sleep at night, sleep inertia, excessive daytime sleepiness, and the consequences of having all of these symptoms on daily life, as we already discussed, on work problem, on family problem, on social problem, and on driving problem. So it's a 14-item self-reported questionnaire. Total score are from 0 to 50. And as you can see here, in this first paper we published in Neurology, we compare untreated IH to untreated narcolepsy type 1 and control. And we were able to define some cutoff that made differentiate patient to control. It was 22 with a nice sensitivity and specificity. And of major interest, because the objective to use this scale is for the follow-up to quantify the symptoms, but also after being medicated. In the group of subject treated versus untreated subject, there is a decrease in the score. So in our hands, it's reliable, it's valid, it's easy to quantify all IH symptoms and the consequences of having these symptoms on daily life. And it seems to be sensitive enough to detect clinical change after being medicated.
Very good. Thank you, Yves. Now, we heard earlier from Addison about how a timely diagnosis and delayed diagnosis can affect her. But let's now hear from Addison's mother, Michelle, and hear what she feels about the importance of an early diagnosis.
What I'd like clinicians to know about detecting IH and detecting it earlier is that not every young person that is coming in presenting with exhaustion or excessive sleepiness is depressed. That it isn't just that they're sleeping or they're bored or that it's a hormonal thing, especially when they're dealing with young women, or that this has an emotional piece connected to it, that it could be something much more involved. If this could have been detected or picked up on earlier, there may not have been all these breaks in her college career. She may be in a different place at this point now. I can't help but think if someone said, there's a sleep issue here. This isn't the depression. This isn't the anxiety. This is not a teenage girl being, overly emotional about what's going on at school. It's not a hormone issue. We need to dig deeper and find out why she is sleeping so much, because that's what I've shared with every doctor that we have been to. Then maybe there could have been a remedy, a quicker resolution, and her life wouldn't have been put on hold as long as it has been.
Very good. So we've heard from Michelle's mother about the difficulty with diagnosis and the impact of the symptoms on Addison. But yeah, this is where I think, Yves, your scale can come into great help in terms of our understanding about the severity of the symptoms in a patient. Perhaps if we go back to that IHS scale, can you talk to us a little bit about the scoring of it and how the severity of the condition relates to the score on the scale?
Yes, thanks, Michael. So we did a second study just published a few weeks ago to quantify the clinically relevant score range, as we often have in scale, for insomnia, depression, restless leg. We like to categorize patients with mild, moderate, severe, and very severe subject. It's again self-report, but it's nice because we want to improve a lot severe and very severe subject with medication. And if it's not enough, you can switch or increase the dose of the medication. We will discuss that later on. So in the second study, we include a large number of patients with IH. We define the component. There's 3 components on the scale. on daytime functioning, on sleep duration and sleep inertia, and on napping. And we confirmed that IHSS is lower in treated subjects than untreated subjects. And we also defined the minimum clinical important differences. The meaning is that if you give a drugs, you need to decrease the scale at least 4 points if your treatment is enough effective. If not, the meaning is that is not enough and you need to change your management. So really, I think that these findings, this different score range, this minimum clinical important differences should stimulate all clinicians to use this scale in the clinic and also in research, but we are discussing today about the clinic. And the patient will complete it himself. So it's to replace the Epworth Sleepiness Scale. It's a scale dedicated to IH.
Just to clarify, Eve, do you regard this scale as being a diagnostic scale or more a scale used once the patients receive the diagnosis of idiopathic hypersomnia to assess severity?
Yes, correct. I think it's a second option for sure. You need to quantify objectively the symptoms as we discussed, MSLT, long sleep duration, to exclude others, to exclude other disorder that may mimic the symptoms. So it cannot be a scale for diagnosis, but when you diagnose the patient, you quantify the severity of the condition to propose medication and non-pharma management as well to improve the quality of life of the patient. So the answer is easy, is second, is not to diagnose, is to quantify the severity of the condition.
So when we are considering diagnosis, Nancy, what do you think that clinicians out there, what are some of the most important points for the clinician to understand in trying to make this diagnosis?
Well, I think the clinical history is so critically important. It's more than daytime sleepiness. And so it takes, I think, some patience and some clinical investigation to really understand the burden of symptoms and exactly what the symptoms are. I think this is first and foremost. And secondly, it's important to recognize the pitfalls of the way we test patients in the United States with the MSLT. I've seen so many patients who came for a second diagnosis or a second opinion, and either were diagnosed or were not diagnosed, but based on an interpretation that implied that the MSLT is the gold standard and always valid. And I think when I see patients who may not have the test results on the MSLT that I might expect, I always go back to the day of that test, and try to understand what happened that day. And very often, it's not so difficult to see that was likely an invalid test. And so from both the clinical standpoint as well as the testing, it's not as straightforward as the ICSD criteria may suggest.
Very good. Eve, what do you think are some of the important points that the general clinician should know about making an early diagnosis of idiopathic hypersomnia? What should they focus on? Is it excluding other types of disorders? Is it trying to determine the primary symptoms of idiopathic hypersomnia? Where should the clinician go in making this diagnosis?
Yes, the problem is that in Europe, at least, that excessive daytime sleepiness or long sleep at night is not recognized as a symptom that may be explained by a disease. It's mostly symptom that you are lazy. Again, IH start in adolescent, in young adults, and you need to work. You take care about kids sometimes. You need to win money. You need to do your university exercise and so on. So mostly it's a little bit change in your life, and in most of cases, in even all of cases, there is no other diagnosis that has been done. The long delay of diagnosis is because there is no recognition that the symptom of the patient, the complaint, is not organic. is just they are lazy. They have not enough magnesium, not enough vitamin, not enough, So the problem is when you recognize that sleepiness, long sleep at night, sleep inertia is problematic, I think you win the party, because they will go to a neurologist or sleep lab, and hopefully they may make a good diagnosis to differentiate, as we discussed already. You need to exclude for sure depression, OSAS, narcolepsy, and so on. But the first point, the long delay of diagnosis, is to recognize that symptoms may be referred to a sleep disorder and not just to a normal, healthy condition.
Very good. Well, we've heard a lot about the symptoms of idiopathic hypersomnia and about making an early and accurate diagnosis of idiopathic hypersomnia. And now this brings us to our third goal and learning objective. And that is that we want to look at the efficacy and safety of therapies for idiopathic hypersomnia and look where there are problems and gaps in the management of patients with idiopathic hypersomnia. But before we go on and discuss that, we have a question for our audience again. So let's have you answer this question. How confident are you in developing safe, effective treatment strategies to optimally manage idiopathic hypersomnia? A, not confident at all. B, somewhat confident. C, confident. D, extremely confident. E, I don't know. So please vote, and we'll discuss the results a little later. Okay, so Nancy, patients with idiopathic hypersomnia tend to get treated with a big variety of different medications. There are many alerting medications out there. And as this disorder has not been widely recognized, patients tend to get treated with a variety of things. Can you tell us a little bit about the treatment experiences of patients who have idiopathic hypersomnia?
Sure. So these data are, again, from the Hypersomnia Foundation registry, the web-based registry. And here we see in the first column the symptoms present within the last 30 days. So 82% of these patients were on medications at that time. And in the right column, the symptoms at baseline, or at when the patient was at their worst, which I think was at baseline for most of these patients. At the bottom, you can see the large number of different agents tried. So over 50% were on at least one stimulant, 38% were on modafinil or armodafinil, and then a spattering were on other agents. And what we see comparing the last 30 days of symptoms to their baseline at their worst symptoms is that while there's a significant reduction in all of these symptoms, symptoms persist in many of these patients. So you can see that excessive daytime sleepiness, requiring multiple alarms to wake up in the morning and having trouble waking up in the morning. These persist in over 60% of patients. And then cognitive complaints, brain fog, difficulty remembering persists in over 50% of this large cohort. So this really is in line with my clinical experience that available medications, particularly at the time of this survey, fail generally to adequately manage the important symptoms in most patients. And there's a lot of improvement to be had, hopefully, with future pharmacotherapies.
Okay, very good. So what we've found is that there are only a few medications that are sort of currently recognized as being particularly helpful for idiopathic hypersomnia. Can you discuss what the current treatment strategies are?
Sure. So this slide summarizes the pharmacotherapeutic strategies for IH. A lower sodium oxybate is the first and the only FDA-approved drug for IH in adults. Generally, historically, we've treated patients with IH like we treat patients with narcolepsy. In 2021, the AASM published the updated guidelines for the treatment of CNS hypersomnias and provided a strong recommendation for the use of modafinil, and that's based on a couple of randomized controlled trials, and conditional recommendations for a number of others, including clarithromycin, methylphenidate, pitolisant, and sodium oxybate. Of note, lower sodium oxybate was not available when these guidelines were published. I think it's also important to remember some of the basics, some of the conservative or non-pharmacological therapies that often work in conjunction with medications. And that includes maintaining good sleep hygiene, morning lights that can be very helpful for patients who have sleep inertia, even caffeine, strategic caffeine use. Strategic naps tend to not be as effective in patients with IH as they are in narcolepsy, but they can be effective in some patients.
Okay, so can you give us a little bit of an overview then of what the studies have shown with these medications for IH?
Sure. So there have been a number of studies. This slide summarizes most of them. And I'll say off the top that most of these were observational studies with relatively small samples, with the exception of the modafinil trial and the clarithromycin trial that were randomized controlled studies. You'll note under the conclusions that the Epworth Sleepiness Scale was the primary endpoint in all of these studies. And the Epworth Sleepiness Scale measures subjective propensity to doze during the day. It does not measure some of the other core symptoms of idiopathic hypersomnia, as Yves alluded to when he was discussing the IHSS. So most of these studies show some improvement in the Epworth Sleepiness Scale score in the range of 3, 4, 5 points, which is useful. But again, none of these studies measured symptoms, the comprehensive symptom assessment of patients with idiopathic hypersomnia.
Okay, so can you tell us about modafinil? What do we know about modafinil in treating IH?
So there have been a couple of studies. This study is the newest and methodologically most robust. It was performed in Japan, and it included 2 assessments. On the left is the Japanese Epworth Sleepiness Scale score after treatment with 200 milligrams of modafinil versus placebo. So this was a double-blind randomized trial. And on the right, the maintenance of wakefulness test. So you see the mean sleep latency on the y-axis with higher numbers, meaning more wakefulness. So higher is better. The title here says IH without long sleep time. I don't think the investigators meant to exclude patients with long sleep time, but there were simply very few in the cohort that had long sleep time. So the primary endpoint was the MWT. And one sees on the right no difference that's significant in terms of improvement in the placebo group, which is in gray, and a significant increase in the MWT, signifying improvement in the modafinil patients, which are in the green color. And that difference between groups is about 5 minutes, which is important. On the left, we see Epworth Sleepiness Scale scores. So again, in gray, the placebo group doesn't change very much. From 18 to 16 signifies significant subjective daytime sleepiness, whereas the modafinil group has a swift improvement in subjective sleepiness that's maintained over the 3-week period. This study also looked at the CGIC and napping and found improvements in both of those measures with fewer naps reported during the day by patients on modafinil. So overall, this was a positive study. both in terms of subjective and objective measurements.
And tell us about patolazone, Nancy.
Yeah, so patolazone is our first and only histamine 3 receptor antagonist. And this study was an observational study that recruited patients with idiopathic hypersomnia who were refractory. So these patients had already tried multiple other agents and had persistent symptoms. The Epworth Sleepiness Scale was used as the primary endpoint in this study. And one sees really no differences in the baseline or outcome measures between patients with long sleep time or long sleep or short sleep time. The investigators did find a mean change of about 2 points on the Epworth Sleepiness Scale, which is significant from baseline. They also, however, found that over 60% of patients discontinued treatment over time. And this was mostly due to a lack of efficacy, but also in some cases was due to side effects. So this suggests some potential role for the use of pitolisant in IH, but certainly warrants larger studies, randomized control studies, and inclusion of symptom assessment that is more comprehensive than what the Epworth Sleepiness Scale score provides.
Good, thank you, Nancy. Eve, Nancy mentioned that the only FDA-approved treatment for idiopathic hypersomnia is lower sodium oxybate. You played a pivotal role in those studies that evaluated low sodium oxybate in IH. Can you tell us about the findings of those studies?
Yes, Michael, thanks. I was lucky to be involved in this study because it's the first study, large study, with more than 100 patients involved. Is 154 patients involved and 115 randomized. So it's a complex study. I will be brief, but all patients with IH, with or without long sleep time, could be included in drug-naive condition or already managed with stimulants, but they need to be with stable dose during the whole trial. So we had this LXB, so the 92% reduction of sodium as compared to Xyrem. So the name is Xywave, and we give the Xyrem in open titration study once nightly or twice nightly with different dose. The mean was 7 grams, but you can go from 4.5 to 9 grams, and you put that in open label titration individual study over 10 weeks, and after you need to have a stable dose for 2 weeks, and after the patient is randomized to continue the LXB or to be randomized to the placebo. And here is the primary endpoint is the Epworth Sleepiness Scale. You can see a decrease in the open titration study along the 2 first months, and after when the patient is randomized to the placebo, there is as expected an increase in the Epworth Sleepiness Scale, but the Epworth is stable in the group that continue the LXB in the double-blind randomized period of the 2 weeks. So the primary endpoint was reached in terms of persistence of efficacy in the open label study, and especially in the double-blind period, there is a differences between placebo and the LXB. Next slide. And of interest, we confirmed that the efficacy of the LXB in IH is persistent in different subgroups. The different subgroup is male versus female. I'm not sure that we touched that already, but IH is mostly a female disease. We do not know the reason why. That contrasts with narcolepsy with the similar sex ratio, but we do not why, but is mostly in female, but there is no differences in effectiveness of LXB between male and female. I already mentioned to you that you can give the drugs one nightly or twice nightly. In narcolepsy, you know, it's mostly twice nightly, but patients with IH sometimes cannot wake up in the middle of the night to take the second dose. And for this reason, we accept in this study that patient may take just once nightly, mostly with higher dose than if they perform twice nightly. So the mean dose is again around 6 grams per night, and we find no differences, as you can see. So it works in the two regimen. Again, of major interest, we compare with long sleep time and without long sleep time. As you can see here, there is few subjects with long sleep time, but in both conditions, LXB works. So that's of interest. The form with long sleep time is mostly in Europe and without long sleep time in US. And patient may be managed with stimulants at baseline with modafinil, amphetamine, methylphenidate, or may be drug naive. And as you can see here, LXB works in both conditions. So it could be just monotherapy for IH subject, but it could be add-on therapy for patient already managed with other drugs that didn't improve the patient enough. So you can combine drugs. And this trial allow to answer all of these questions. So it's very important trial because it able to assess different subgroup efficacy and symptoms, and we will discuss that. Next slide. The secondary endpoint, there's two secondary endpoints. The first is the PGIC, so the change in the patient global inventory. And as you can see here, there is a huge improvement during the randomized double-blind withdrawal period compared to the placebo during the 2 weeks. So it's highly significant that the patient clearly report improvement with LXB compared to the placebo. And last, the second endpoint, the primary secondary endpoint, with the PGI is the scale we just mentioned already, the IHSS. So I was very happy that this scale was approved by FDA and was included in the trial, because you can look for long sleep at night, to sleep inertia, and to EDS. EDS is assessed already by Epworth, but here is a more comprehensive scale. And it is almost the same shape of the curve, with decrease in IHSS during the open label titration study after it's a stable period of 2 weeks, and the patient are randomized, remember, over 2 weeks to continue the LXB or to be on the placebo. And as you can see here, after 2 weeks, there is a huge change. They almost go back to the baseline, the 28 on IHSS, and they are 31 at baseline. And the patient that continue the LXB are almost stable compared to the stable period. So again, this secondary endpoint confirm that LXB is really effective, not only on EDS, but also on long sleep at night, sleep inertia, and the consequences of having the symptoms on daily life. Next slide. And this is the last slide I want to share with you on the results of this very important study published in Lancet Neurology several weeks ago between US and Europe. And here is the last symptoms we touch on the sleep inertia and also the total sleep time. The figure is for sleep inertia assessed on visual analog scale. This is complementary to the sleep inertia assessed on the ISSS scale. And as you can see here, there is a huge decrease in the open titration study on the sleep inertia compared to the baseline. And again, the patient randomized to keep the drugs are stable, and a patient randomized to the placebo go back to the baseline, 55 on the visual analog scale from 0 to 100. And of interest, we were also interested in looking at the self-reported 24 hours total sleep time. So that includes nocturnal sleep time and nap duration. And there is no graph here, but we reported that LXB reduce the total sleep time over the 24 hours. So really it's effective, and compared to what Nancy reported on patolazone, modafinil, amphetamine, methylphenidate, that's clear that works, but on sleepiness. But here, these drugs may work on different symptoms of the disease.
Good. Well, thank you very much, Eve, for that discussion about low sodium oxybate and idiopathic hypersomnia. So, Nancy, how about the safety of these medications for the treatment of IH?
Yeah, so these medications are generally safe when patients are monitored closely. Common to all alerting medications, as well as sodium oxybate and lower sodium oxybate, are side effects that include anxiety, GI symptoms, and even insomnia. And these are often transient, mild, and dose-related, and resolve over time, sometimes requiring a little bit of back titration before going forward again. Pitolisant is the only one that is not scheduled, and so it's easy to use and safe. In addition to causing anxiety, insomnia, and nausea, and the insomnia is likely because of its long half-time, about, I think, 11 hours. Pitolisant is also associated with increased QT on EKG, and so it's important to recognize that, particularly if patients are on concomitant medications that might also increase QT. And it's also important to identify patients who are on CYP2D6 inhibitors or CYP3A4 inducers, because pitolisant's metabolism will be altered by those drugs. Modafinil and armodafinil are Schedule 4. Again, their side effects are fairly easy to manage and transient. Modafinil and armodafinil, like pitolisant, are inducers of CYP3A4, and so oral contraceptives will be metabolized more rapidly, and for that reason, they may be less effective, and so there's a risk of oral contraceptive failure for women using those medications for contraception. And so we need to counsel women in their reproductive years about that in the use of modafinil and pitolisant. Finally, with sodium oxybate and lower sodium oxybate, there are a few other symptoms that have been reported over time, including decreased appetite and a little bit of weight loss, hyperhidrosis, as well as parasomnia. And most of this parasomnia is likely related to lack of emptying the bladder before going to bed at night. And so patients may have some enuresis. Patients can also sleepwalk. And usually these are not injurious nighttime behaviors, but they can be in rare circumstances.
Very good. Well, look, thank you very much, Nancy and Eve. That was a great discussion about treatment. So let's come back to our audience and ask them those questions again. So the first one is, now, how confident are you in developing safe, effective treatment strategies to optimally manage idiopathic hypersomnia? A, not confident at all. B, somewhat confident. C, confident. D, extremely confident. Please vote. Okay, very good. So I think we've increased the degree of confidence in the audience since our presentation. So that's great. Let's move on to the next question now. And we go to the next question, which is, when evaluating a patient with idiopathic hypersomnia, now, how important is it to assess the quality of life and functional impact of IH? A, not important at all. B, somewhat important. C, important. Or D, extremely important. Please vote. Okay, so the degree of confidence has clearly gone up for everyone, and that's great. I think we've had an excellent discussion about the important elements in making an effect on patients. Okay, so let's go to the last question. How confident are you in accurately diagnosing idiopathic hypersomnia? Not confident at all, somewhat confident, confident, extremely confident. Please vote. Okay, so I think this poll that we're seeing here now is on effective treatment strategies, and that has greatly increased the confidence since starting the program. Okay, so Nancy and Eve, thank you for your insight on strategies to address the unmet needs of individuals with idiopathic hypersomnia. Our main conclusions are listed here. The burden of IH is extensive, encompassing diminished quality of life, impaired cognitive function, poor work performance, mood changes, and psychosocial dysfunction. And accurately diagnosing idiopathic hypersomnia can be a challenge. And currently, there's only one FDA-approved treatment for IH, and it's been shown to show benefits across a number of different domains. I think we'll move to our next slide, which is the SMART goals. So we want to sort of close out this program with these SMART goals. SMART stands for smart, measurable, attainable, relevant, and timely goals. That is, these are goals that you can use in your clinical practice to help manage your patients with narcolepsy, with idiopathic hypersomnia. So the first one is that at every visit, assess the burden of idiopathic hypersomnia on the patient's daily functioning, including its negative impact on work and psychosocial functioning and quality of life. Use evidence-based strategies to facilitate the early accurate diagnosis of idiopathic hypersomnia, and incorporate into treatment planning the latest clinical evidence on FDA-approved strategies for IH. Okay, so we have quite a number of questions from the audience. And so if we can go to those questions. And so the first question is, how long after the first dose does lower sodium oxybate take to be helpful for IH symptoms? Saying that patients on stimulants notice a difference sort of immediately. So I'll pass that to you, Eve. What do you think? How quickly does the effect of oxybate come on in the patient with IH?
Yes, good point. In narcolepsy, it takes weeks, especially for EDS and cataplexy. So I think that in IH is almost the same. Is not like stimulants. It will not work in 1 day or 2 days. First, you need to increase the dose. We have less experience for sure in IH than in narcolepsy to be sure that which is the best dose for the subject. In narcolepsy, we like to go up to 9 grams, but in IH, often 6 grams could be enough. So you need to adapt the dose. That's an issue, and the escalating dose is probably not exactly the same as for narcolepsy. We started with 2 grams per 125, and we increase after a few weeks to 3 grams twice at night. So the regimen is a little bit different, also with long sleep time, with sleep inertia. Sometimes they cannot wake up in the middle of the night again. So to answer the question is quite complex, but to be clear and brief, I think you need time, at least one month, I may say, and you need to adapt the dose carefully and over a minimum of 2 weeks before increasing the dose. The safety concern is an issue as well. It's not the same patient as for narcolepsy, and you need to take care about nausea and the BMI. That may be an issue because they are not obese compared to narcolepsy. So it's quite long, and you need to go very slowly in increasing the dose. And probably the correct dose, depending on the BMI, is 6 grams and not 9 grams, 6 to 7 grams.
Okay. So Nancy, there's a question here about in actual practice, how long are you seeing patients, or how do you follow them up? So when you first started, when would you first see them back after starting, and then at what intervals after that?
Yeah, so I think this is variable. It may depend on how well I know the patient and how easy it is for them to come back. We're seeing a lot of these patients virtually now, but I like to see patients right before they start their sodium oxybate or lower sodium oxybate, so that we can re-educate them and make sure they understand the instructions on how to administer this and the safety precautions. And then typically it's 2 to 4 weeks later. I will titrate them a bit through my chart or the electronic health record or through telephone calls before they come back. And then after that, depending on how well they do, I may see them at 3-month intervals, particularly if they're on other medications like traditional stimulants. But I think it's highly variable.
Okay. One of the questions is that can you use low sodium oxybate in teenagers? The answer to that is yes. Low sodium oxybate has been approved for the treatment of children from the age of 7 and up for narcolepsy. For idiopathic hypersomnia, it hasn't been studied in children, and so for idiopathic hypersomnia, it's more in the adult range, in the older teenage group, rather than the young teens. Okay, so someone's asking about does serotonin play a part in idiopathic hypersomnia, and why do antidepressants have a part to play in the treatment of idiopathic hypersomnia? Eve, maybe you could answer that one.
Sorry, could you repeat the question about serotonin, you say?
Yeah, they're saying, does serotonin, is that involved somehow in idiopathic hypersomnia, and do antidepressants have a role to play in IH?
Yes, I'm not sure about that. There is always, as we discussed already today, that depression is a differential diagnosis, but it's not completely clear because you can have very burden symptoms and not recognized, and you can have depressive symptoms as a consequence of having IH not yet diagnosed and not yet correctly managed. So it could be a consequence of the disease. So if you treat the disease first, you can improve the symptoms, and with drugs we discussed today. So I'm not sure that to treat with antidepressants is a good way to go. You can treat mood disorder associated with the complaint of sleepiness or hypersomnia, but I'm not sure, and I'm not convinced that serotonin, SSRI, or SNRI may work on IH patient. You need to make a differential diagnosis between mood disorder and IH again. So not very convincing for me, the results so far.
Okay. Nancy, there's a question here about incorporating previous workups. As we mentioned in the discussion, many of these patients have seen quite a number of physicians before they come to a sleep specialist, and they've undergone quite a variety of tests. So where do you go when they've had tests done, say, several years earlier, and do you repeat the testing? How do you evaluate those previous tests?
Yeah, I think this can be a challenge too. When the testing is accessible to me and my clinical history and their response to therapy matches with the diagnosis, and their testing is reasonably matching as well, I would not necessarily repeat testing in those patients. However, when the diagnosis is unclear, I'm questioning it, or previous providers questioned it, or when I review the records that might suggest to me that perhaps the MSLT may not have been valid in that situation, or the patient reports that they feel their test wasn't invalid for whatever reason, then I would try to repeat the test. And that can be challenging because sometimes insurance is not going to allow us to do that. So I think that this is quite individualized. In fact, I've got my first patient, Eves, is in the lab today for a 32-hour protocol.
Excellent.
We'll see how it goes. I might be calling you. But this patient had 2 prior PSG MSLTs, and insurance wouldn't pay for another one, even though they were clearly not done the way I might have instructed them to be done. And she has the phenotype of IH, and she's not able to get accessibility to the medications that she really needs because she doesn't have the diagnosis. So many variations on the theme, I think, Michael.
I would agree with you. Very often I get prior test results, and when I look at them carefully, I find something has influenced it. Either the patient has a delayed sleep pattern when they had their testing, which is going to affect the results, or they didn't get enough sleep at night. So it's always important to look at those prior sleep results very carefully and decide whether they really need to be performed again under optimum conditions. And in fact, on that same sort of topic, Eve, there's a question for you here about extending sleep time. And somebody's asking, is it important to extend sleep time in these patients to be able to see if they're just sleep deprived? And should that be a first step?
Yes, for sure. It's not enough, but it's mandatory to start with that. When you discuss with patients with IH, they often sleep 2 hours higher during the weekend, so the day off compared to the day on. But it's not enough, because when you go from 7 hours to 9 hours, because nobody can sleep 11 hours, 12 hours, because you need to work to survive, and it's almost impossible. So it's not enough, but it's mandatory to keep the patient, and even for the diagnosis, I'd like to discuss, when you are in vacation, what is your favorite period of time? Did you wake up at 11 a.m., at noon, at 2 p.m.? When you do some naps, is it 2 hours of naps, 3 hours of nap? And how can you cope between naps, and after awakening, sleep inertia disappear or not when you are able to sleep 10 hours or 12 hours? So they may be a little bit better when you sleep 9 hours compared to 7 hours, but it's not enough, because they lose their time, because you will see, if you do this 32 hours of recording, they can sleep in my lab 24, 26 hours, and after, when you wake up then the second night at 7 a.m., the second night, they say, hey, my God, why did you wake up me so earlier? And so they did not recover, they have huge sleep inertia. They say, hey, the protocols stop right now because we need to move on. You cannot sleep 1 week in my lab. They say, hey, you should have not wake up me so earlier. So, it's not very helpful to let them sleep hours and hours and hours first, but second, they should not be too much sleep deprived. So the response is in between. They need to wake up probably 9 hours during the day off.
Yeah, there's a question here about differentiating between IH and a long sleeper. I think the main difference there is that in order to have a diagnosis of idiopathic hypersomnia, you have to have a complaint of excessive sleepiness or an excessive amount of sleep in the 24-hour period. People that are long sleepers generally don't have the same sort of sleep inertia when they wake up, assuming that they're getting their regular long period of sleep at night. And then when they do wake up, they're more alert than the normal during the daytime, so they don't have that excessive sleepiness. So, but sometimes it can be hard to differentiate, particularly if you have somebody who has a sleep study that cuts them very short, a long sleep, a shorter sleep at night in the lab, and then they tend to be sleepy during the day and then will show abnormal REM onset. So it's an important differentiation to consider. We're sort of running out of time here, and so just one final question here, maybe for you, Eve, again. It's about orexin levels, and they asked asking if we can describe the difference between the orexin levels and type 1 narcolepsy, type 2, and idiopathic hypersomnia.
Yes, no, this is very clear. In narcolepsy type 1, it's gone. Orexin neurons are no more active. They are dead or they are not dead. This is another story, but they are no more active. So the meaning at the end is if you do CSF lumbar puncture, it will be decreased. This is clear. For IH, this is clear also, especially the form with long sleep time. The orexin measurement in CSF, we did it in my lab many times, probably more than 100 patients. They are above 200. So they are completely normal. And by definition, I may say, but this is when you make a good diagnosis of the form with long sleep time. What is tricky is in between, because we discussed a lot today that there is some overlap between NT1, NT2, and NT2 and IH. So when you are very sleepy during the day, no cataplexy, and sometimes not, orexin could be in between, and more and more. And there is 2 papers accepted in sleep recently, one from my lab and another one from the Netherlands. So you can see patients with in-between orexin measurement, 120, 150. So they are in the gray zone, So it's hard to say if everything is normal. So I have some doubt that NT2 may be with partial orexin activity, but nobody knows clearly. I think
Well, we've already run out of time, and yet we have so many more interesting questions. There's just one final question I'd like to answer here, because I think it's an important one. It's from an internal medicine doctor, and he says that he has a very busy practice, and how can he test for IH in his practice? I think the important thing here is that he recognizes when the patient has a problem, and he's excluded things like simple sleep deprivation, and he feels that there's still a problem with excessive sleepiness. Refer to a sleep specialist to find out exactly what's going on, whether they have narcolepsy, idiopathic hypersomnia, or some other sleep disorder. So I think the recognition of the sleepiness is the most important thing. But it's important to know about idiopathic hypersomnia, because these patients are going to come back to you on treatment, and you need to know what their primary problem is and how it's affecting them, and what treatments that these patients are likely to be on. So you need to know about IH, but you don't need to do the diagnostic testing. Leave that to the sleep center, but do recognize when there is a problem. Okay, well, I think we have to finish at this point, and I'd like to encourage our audience to visit the Sleep Disorders Hub for additional information, clinical guidelines, resources, and patient education about sleep disorders. To receive CME, CE credit for today's program, complete the post-test and evaluation. You'll be able to download and print your certificate immediately upon completing those forms. So I'd like to thank you for your participation and providing best care for your patients. And I'd particularly like to thank our faculty, Nancy and Eve, for such an excellent presentation on idiopathic